I am Dr. Derek Lee. It's my pleasure to welcome Dr. Waleed Kishta. He's associate professor and a pediatric orthopedic surgeon. He's head of orthopedics at Master University Medical Center in Hamilton, Ontario, Canada. Welcome, Dr. Kishta.
Welcome, Dr. Derek Lee. Thanks so much for the introduction, and thanks so much for inviting me. And more thanks for your advocacy for scoliosis.
Oh, my pleasure. I'm always looking to learn about scoliosis, whatever age group it is, going from infantile to, adult degenerative scoliosis. And today we're going to talk a little bit more about rare types of cases and syndromic scoliosis as well. Correct?
Correct. Yes.
Okay. Let me hand it off to you, and I'm going to ask questions along the way. So let's start the journey.
Awesome. I'm going to share my presentation. So today we'll talk about syndromic and rare scoliosis conditions. Why syndromic scoliosis are different? Because the syndromic spinal deformity surgery are complex. It needs multi-system involvement, and because of the disease commonly involves multi-systems. Complication rates may exceed 25% compared to adolescent idiopathic scoliosis, and multidisciplinary approach is mandatory to minimize the risk of complications. Here's a list of some of the common syndromic diseases like Marfan syndrome, Ehlers-Danlos syndrome, other connective tissue disorders, muscular dystrophy, osteochondral dystrophy, neurofibromatosis, Noonan syndrome, Vater or Vactor syndrome, Angelman syndrome, Rett syndrome, Prader-Willi, osteogenesis imperfecta, trisomy 21. Each one of these has its own issues and complications and risk. We usually start by addressing the general considerations, taking history by preoperative evaluation with a comprehensive medical history and review of the systems. From the history point of view, we look at the medication records, nutritional status, patient has GT, G-tube or not, history of recurrent pneumonia or not, or aspiration, past surgical history, ambulatory or not, other systems involved like cardiac, pulmonary, kidney, or other systems. Cardiopulmonary assessment must be done through review of the heart, respiratory diseases, pulmonary complications are very common in syndromic scoliosis. Sleep apnea is another common thing, history of pneumonia, asthma, prior aspiration events, and any history of prolonged intubation. We usually consult the pulmonologist, and we always follow the recommendations. Cardiopulmonary, cardiac myopathy, and valve problems usually need echo, cardiac consultation, and sometimes cardiac MRI based on the cardiology recommendations. Neurology is another big system. So we, again, look at the history of seizures. Medicine like valproic acid can increase the risk of bleeding, bladder dysfunction, using indwelling catheters or adhesive dressing issues. Some of the kids come with hydrocephalus, and some has intraspinal abnormality like tether cord diastematomyelia, which is a split cord, syrinx, Chiari malformation, or dural ectasia. And usually we do MRI for these kids preoperatively. These conditions are famous with malignant hyperthermia, so need a special precaution, especially with anesthesia, osteogenesis imperfecta, Duchenne muscle dystrophy, and Becker's dystrophy. Osteopenia and osteoporosis are also common with osteogenesis imperfecta or kids on steroid, and there are too many conditions also have a risk of osteopenia. Eyes are important to check, and ears. Some kids come with trochlear implants, so have to be careful with the halo traction, and also with a cautery and all the safety precautions. Now we'll come to the surgical part, which is the more exciting to everyone as to how to make a surgical planning for these cases that usually have a complex, high degree of scoliosis and usually rigid. One of the best ideas is to get the halo traction preoperatively that help us to straighten, and sometimes use the halo for a period of 2 weeks to 6 weeks. A few times we go for a few months. Considering growing rods in younger children, that's another consideration. We know that the lung reaches maturity at the age of 8, and below the age of 8, we will help them to achieve the growth together with correction of the scoliosis. Consideration of the techniques, going anterior, posterior, vertebral column resection, doing osteotomies, doing facetectomies, and using the 3D CT and 3D print is very helpful for the surgical planning. One of the fortunate things at McMaster Children's Hospital is we have the complex care team, and we do the preoperative planning together. And the team is usually formed by the complex care pediatrician, orthopedic surgeon, and general pediatrician, ICU staff, occupational therapist, physiotherapist, dietitian, neuromuscular specialist, and nursing staff, and anesthesiologist. Intraoperative traction is one of our best tools that we usually use, give us some correction before we start the surgery. We usually like the Gardner-Wells traction for the head and skin traction for the legs. Some people use the halo and some people use pins, skeletal traction, but we're happy with this. We use the cell saver and tranexamic acid to control the bleeding. Also, neuromonitoring is very important, a useful tool to check for neuro changes intraoperative. Positioning is very important, and taking care of the bony prominences. Some of these kids has hip issues, flexion deformities, so I have to consider this with the positioning. Imaging, the fluoro and the O-arm is very useful tool, and we use a navigation system now, and it makes all the screws placement more accurate. One of the screws placement that very helpful with the navigation system is using the S2 LX screw, and the navigation made it very easy, especially when we go from T2 to pelvis in certain syndromic cases. I'll start with more exciting part of case presentation. The first one is a kid who presented at the age of 9 with congenital myopathy and getting progressive severe scoliosis. And he had multiple admissions to the hospital due to recurrent pneumonia, and was very severe pneumonia. Initially, we thought of treating him with traction and having some sort of magnetic rods or growing rods. But because of the deterioration of the condition and he reached almost 9, we found that with the evidence, fusion can be superior in these cases, as you can do one surgery and stabilize the patient, and they do well after one surgery. So this is what we did. We did posterior spinal fusion from T2 to pelvis, stabilized him, and he did certainly very well in terms of pneumonia. He stopped having the aspiration and pneumonia afterwards. One of the techniques we used in this case was only facetectomies plus intraoperative traction. We'll move to case number 2. This is a patient who presented to us at the age of 9. She had a congenital Marfan syndrome, and she had a known cardiac issues. We, again, can go with the fusion right away, but we found that she's still growing, so we decided to go with magnetic rods. With the magnetic rods, there are 2 types in terms of the length of the actuator for lengthening. One is 70 millimeter and one is 90 millimeters. 90 millimeters can give us length and stays longer. It's a common time for lengthening, might take 2 to 4 years. She has been doing lengthening for 4 years now and is still working. And she's gaining a lot of height. So we'll still continue to lengthen with the magnets in the clinic. We do it here in McMaster every 3 months at the clinic with lengthening of the magnet through the skin. She has been doing very well so far. So we'll continue lengthening until she stops. And then we'll switch to fusion surgery at the end. Hopefully, some people are working on a study now to look if we can leave the magnetic rods and not to have to switch to permanent fusion. But so far, the standard is to convert to permanent fusion at the end.
Dr. Kishta, with these types of cases, they're so complicated. And how do you choose which particular technique for this particular case? Because sometimes with every 3 months adding lengthening the rods, there's also a higher complication rate with these types of cases as well. How do you try to navigate the pros and cons in terms of choosing, for instance, this particular technique above others?
Yes, it's a very good question. The initial traditional rods where we insert the rods and do the lengthening every 6 months by open surgery. And early in my training, I found that the complication rates are very high. So you open the skin and you get skin dehiscence and infection were high, especially with these kids. Also putting them under every 6 months under anesthesia increase the risk. And then there are different other techniques came for the growing rods in younger kids. It's like the Sheller rod or Lucitroli or these other things that grow by itself. It shows that there is some ions increase in the blood from the corrosion. And there is a lot of development for the Lucitroli now done by Dr. Waleed and the team in Montreal to avoid the metal-on-metal corrosion, and has been successful so far. But again, found the Lucitroli might work for smaller curvatures, not the severe curves, and it has to be a little bit more flexible to have better success rate. The other thing with the magnetic rods are very expensive. So have to be very selective for the cases that really need it and the cases that we need to avoid multiple surgeries. So we selected to the severely sick children who has syndromes that make us don't want to operate multiple times. And that's why we select the magnetic rods. Or some few kids who are not syndromic, but they have a significant early onset scoliosis that we cannot do fusion because they're still growing and we need the organs to reach the maturity, especially for the lungs. So we select some of them to do the magnetic rod device to achieve the growth together with correction of their scoliosis. All of these, we were trying to avoid the fusion until they pass at least the age of 8. And then we have a different discussion with the families about the shape of the body, like discrepancy of the trunk to the lower extremity. Sometimes you offer fusion at the age of 10 and they're still short, then they will get a growth spurt of the lower extremity, so they will look with some discrepancy of the trunk to compared to the lower extremity. There are too many techniques for the ground growth. It doesn't have to be the magnetic rod, but at least in our experience and in our hands, it's a very useful tool for complex cases and for severe curvatures. And there is a study published last year showing that the magnetic rods are effective in severe scoliosis curvatures in early onset scoliosis. The other things that I would like to point to for the magnetic rods, although it's for lengthening and it's non-fusion technique, but due to the high rate of autofusion that happens during the lengthening, so it ends up in a fusion technique. But hopefully after we reach the goal. Another challenge is if we do it for the very young, say if I have a patient who's 4 years old and I'm not able to control his scoliosis by casting and all the manipulations, then I have to do magnetic rod, and his trunk is short, so we'll get the 70 millimeter actuators, and I have to change it in 2 years, then he will end up in about 4 surgeries. And hopefully during the 4th surgery, he wouldn't get the autofusion to prevent the further lengthening. So these are very challenging cases.
Mm-hmm. Does autofusion, sorry to cut you off, does autofusion tend to occur where the screws are located, or is it along the
rod, especially the rod on the convex side? Any rod, whenever it touches the spine, it causes autofusion. Hmm. I know there's a group working now on a study doing one rod only on the concave side, so avoid the convex one touching. Problem with the one rod, it's weak, so you don't want to get stress and breakage on the concave side. And I remember when I started the training, the principles were try to be submuscular, try to put 2 rods, don't put 1 rod. But hopefully we'll see some new outcomes with the study. I'll move to the next case. This one was presented at the age of 5, had also chromosomal abnormality, plus some other stuff, autistic and anxious. Was a very complex scoliosis, has been treated by serial casting to get the delayed tactics idea, to delay the surgery, but she used to change her cast every 4 months, and in her last year of casting, she was showing only progression. The cast was not helpful. Then she had to have something. Because of her comorbidities and autistic features, we decided to do magnetic rods as well. So we did intraoperative traction. We did halo traction first for 3 months. To get some stretch and get some correction. And then we did the magnetic rod. Mom mentioned that she's hyperactive, and so we decided to have a brace on top of the rod just for protection of her mobility. I saw her last month. She's doing fantastic, and it's a 1.5 years now of doing lengthening. And she's still responding to the magnetic lengthening. She has a very nice posture, good trunk. So it's one of the successful magnetic rods things. And I think it's a good one to choose magnetic rods for. So I'll go back to her pre-op and we'll get the post-op so you can see how she's more straight. Mm-hmm. Probably notice the ribs are looking like the closing umbrella shape, but because she's syndromic, so she has a chest wall deformity as well. We move to case number 4. It's a little bit more complex. So this is her at the age of 5. Although she's idiopathic and not syndromic, she's idiopathic early onset scoliosis, but was very, very progressive, and she got a severe kyphoscoliosis, was just chest wall get deformed, and you can even see the discrepancy of her trunk to lower extremity. And this is the one who had halo for a longer time. So we put the halo for almost 6 months until she reached some sort of straightening and correction, and then we did the magnetic rod. She had to change her rod after 2 years, was stopped working, and we had the new magnetic rods. There is a new generation now, and she's doing fantastic with the new generation. Now it's been a year on the new one. So this is her last X-ray. Compared to previously with the kyphoscoliosis, she gained a very good correction. It's good to mention that magnetic rods are very helpful to correct the scoliosis, but not really for the kyphosis, because the lengthening tools make the kyphosis worse. Also challenging to bend the rods for the magnetic rods. The company always tell us, stay 1 centimeter away. Don't bend here, because they want the magnets to work. So we bend at the top, so we get some kyphosis there, and she's doing very well in terms of the sagittal balance. This is another case of the complex cases. This patient was 14, had Rett Syndrome, and they usually have seizures, and they are on valproic acid that increase the risk of bleeding. This is what we talk about, the importance of history and medication history. So she came with a progressive scoliosis, and she's ambulatory, and dad is a hockey coach, and she likes to go with him into the hockey field, and she likes to be active. Was a discussion of going to the pelvis or not, but ended up in going to L4 instead. So did a fusion from T4 to L4, and she's doing fantastic so far. I think we discharged her from our service. She's almost 18 now. So posterior spinal fusion is very helpful, and it's a very good tool, especially for kids who are older than 8 or 10. But again, I need the discussion with the family to make sure they're happy with the end over height and relative trunk height compared to the lower extremity height. Recently, we talked previously about how busy is the scoliosis service at McMaster, and we decided to do a big number of cases during summer. So we're going to another challenging case, and this one was a 13-year-old female presented to us actually by was 100 degrees curve, and over 3 months progressed to 120 degrees. And the amount of kyphosis she had, the amount of rotation was significant. So again, we thought about the strategy and the preoperative planning. It's one of the options to do halo traction for a few months versus staging, doing anterior disc release that can be done open versus with thoracoscopy, and then traction, and then posterior fusion. Then after the discussions with the families, he agreed that we can go ahead and do all in one day. So it was a big challenge. So we didn't do preoperative traction, but we took the patient to our positioned lateral, and then we decided to do the discectomy with thoracoscopy. So thoracoscopic disc release was very successful. We did 5 discs around the apex, and then we repositioned the patient prone. We added the traction, and we did the posterior fusion at the same day. It was a very long day, but ended up in a very excellent correction. She gained 10 centimeters of height at this session. Also, she's corrected to 30 degrees from 120 degrees, benefiting from thoracoscopic disc release and posterior spinal fusion in 1 day.
Dr. Kishta, how long would that surgery take? How long did it take?
It was actually the thoracoscopic discectomy took 2 hours. This is the first part. And the second part took 6 hours of posterior spinal fusion. So with the flip and stuff, we finished around 6 p.m. Started 8, but anesthesia took their time. We finished the thoracoscope around 11. I did, in my mind, I thought if we pass noon with the anterior, I will stage it. Because we will be tired, she'll be tired, everyone will be difficult. But what encouraged me is I found that we finished the thoracoscopy early by 11. Then we said, okay, we have time. Then we flipped and we finished the rest in about 6 hours.
I've talked to other surgeons with respect to anterior versus posterior fusions, for instance, and with the new pedicle screws and posterior fusion technology, most surgeons have pulled away from doing any anterior surgeries and anterior discectomies as well. Do you find that to be the case as well? And you're quite comfortable doing the anterior work based upon your training?
Yeah, it's a very, very important concept, because initially my first day at the fellowship was Dr. Al-Hawari in Halifax, and he's like, come on up. I went upstairs and he was doing anterior, and it was very common and to be trained on anterior. And then over time, I found that it becomes less common procedure, to the point that most of the surgeons are not comfortable doing the anterior because we rarely see it. That's because of the pedicle screws. Now, as the technology can hold the 3 dimensions and can get everything you want from the posterior, but still there are some other curvatures that you cannot do only posterior. And this is one of the best examples. We cannot get this correction with only posterior in this one. So it's important to release these discs at the convex. So when you get the straightening, you have a space to straighten around. So I would say we rarely do it nowadays, but definitely there are certain cases that need it. Some studies showing above 90 degrees, you have to go anterior posterior to do the anterior release first. We still can go with all posterior for 90 and 100, but with rigid one, 120, I think we have to do all the techniques to get the correction.
Dr. Kishta, it seems that multi-level osteotomies have become very popular as well. That would be helpful here, but not as helpful as doing the anterior discectomies, just because you need the physical space to straighten the spine. Is that how it works?
Yeah, and that's correct. The other thing was osteotomies also can be done to help for the posterior correction. So we get anterior and posterior space to get the correction, but that adds more risk to the spinal cord when we get this acute number of correction in 1 day. We found that some other centers doing osteotomies in multiple levels as a routine for the scoliosis. We don't usually do this in all the cases. Studies showing the difference of correction is not that significant when you do osteotomies versus not. So some studies showing the difference between osteotomies and no osteotomies, about 3 degrees at the end. So we don't think it's worth it to put the risk of bleeding, osteotomies, and adding more time to surgery to get 3 degrees of correction. But we do facetectomies as a routine for all the levels, which is a small kind of osteotomy, but only around the facet joint on both sides. Helps for the fusion, helps for some correction. And we do the segmental derotators when we do the derotation at the correction as well. And it's very good and helpful device. So traction facetectomies and derotators are our tricks for the scoliosis correction. We like the double rod technique for the reduction. So both rods at the same time. It's very helpful, especially when we have kyphoscoliosis. Also helpful to decrease the amount of screws pull out, especially for the severe curves when we do the gradual tightening and correction.
For these 90-degree plus cases with such a severe curve, I'm trying to visualize, the spinal column, spinal cord going through that path. When you straighten the spine as much as you do, as much as is possible, is there any issues or trauma to the spinal cord with making such a dramatic correction?
Yeah, this is always our fear, and this is how we get the gray hair over time because of these fears. The spinal cord typically is very close to the concave part, so doing these screws are the most scary thing we do around the concave parts, as the cord is the closest here. Also, the rapid stretching and correction can cause cord ischemia, especially at the anterior cord. So these things are very risky and very dangerous. That's why it's safer if we do gradual correction with the halo first, and instead of doing all at one day correction. But we decide case by case, and we have the neuromonitoring now, and we go easy and slow and take our time. There's no need to be in rush with these cases. Safety comes first, and whenever during any step there's any neuromonitoring changes, we stop, we change, we reverse the last level we did, we would move the screws, go back, and it's okay to close and come back another day as long as we feel safe. Talking about the unusual scoliosis surgery, so during this year we introduced a tether, and I know you're a big fan of tethering, spinal cord tethering, and we found in Ontario it's only done in Ottawa, and then we thought we have to advocate to get this, and thanks to Hamilton Health Science Center that approved it, and we started to do the service in Hamilton, and so we did a case in May. It was Sanders 3 patient who had flexible curve of about 55 degrees, bends to 20 degrees. So we thought that's a very good case to do the tether, and was very helpful that the tether we will get her to intraoperative to about 25 degrees, but this is a standing X-ray at the follow-up. And we did another case in summer, and there is a third one coming next month. So it's not like we have some good case selection for the indications. And as you know, there is a narrow window of selected cases, and it's not going to be a very busy practice with tethering here, because we're still going between Sanders 3 to 5. So we are not doing the above 5. We are not doing the adolescent or adult type of tethering. But the next case is going to be lumbar tether. So the previous 2 cases were thoracic, and the next one is going to be lumbar. We're going to do the hybrid technique on the next one. So my home messages are syndromic scoliosis are complex. we need to work with multidisciplinary team and address the perioperative general concerns and the disease-specific concerns.
All right. Dr. Kishta, thank you so much. But I just want to touch on that you're also doing a little bit of ApiFix as well, correct?
We provide the ApiFix at McMaster Children's Hospital, but it's done by Dr. Devin Peterson, one of our spine surgeons here.
Very good. Thank you so much for your time and your presentation. Syndromic scoliosis, uber complex. And I find that the surgeons who are drawn to these kind of complex cases are so complex themselves. So, because you have certain surgeons who kind of like to just do the standard cases, but you have those certain surgeons who really like complicated cases and they enjoy them. And I'm glad we have surgeons like yourself.
Thank you. I really appreciate this compliment, and it's always a pleasure to feel that you're helping these kids, and it's really making a huge difference, not only to them, also to their caregivers.
Absolutely, and you need someone who will take on these cases for sure, and not everyone can, correct?
Yeah, I totally agree.
Okay, all right. Thank you so much, Doctor, and thank you for presenting, and I'm looking forward to hearing more about McMaster Medical.
Thank you very much for the interview, and hopefully we'll collaborate more, and thanks for your advocacy to scoliosis.